This is the MyHeart.net podcast. This show is produced by Dr. Philip Johnson in conjunction with VitalEngine.com. Please welcome your host, Dr. Alain Bouchard of Cardiology Specialists of Birmingham, Alabama, at St. Vincent's Medical Center, part of Ascension.
Welcome to our podcast on atrial fibrillation, or AFib. If you remember the first podcast we had last week, we described the importance of stroke prevention, as well as the importance of rate control, particularly in certain patients that we want to prevent or avoid or correct the problem with heart failure. Today, we're going to talk mostly about rhythm control and how important it is, maybe for certain patients, to get into a normal heart rhythm. Let's introduce our special guest today, Dr. Richard Vess, who's director of the electrophysiology lab at St. Vincent Hospital in Birmingham, Alabama. Richard is not only a cardiologist, but also an electrophysiologist and specialized in heart rhythm problem and with particular interest in atrial fibrillation. So, Richard, thank you very much for joining us today on our podcast, AFib treatment and why rhythm control may be important on some patients.
Thank you so much. I really appreciate you having me. I really enjoyed our first session and talking about atrial fibrillation, the importance of recognizing it by patients. And then, as you mentioned, we also talked about how important it is if patients are having a rate control strategy that their heart rate be adequately controlled. We talked about, just as you just mentioned, how a lot of patients can develop cardiomyopathy or congestive heart failure if they don't have an adequate control of their heart rate. And looking forward to talking about rhythm control today and exactly what that entails, because it's actually a somewhat complicated topic.
Well, exactly right. I mean, why should we bring the patient back into a normal heartbeat? I mean, does it really matter that much? Who benefits from that? And does it actually, do you live longer if you're in a normal heartbeat?
So it's a great question. So just to review a little bit, when we refer as physicians to rate control of AFib, really what we mean is it's a strategy that is designed to slow the heart rate down in patients who have atrial fibrillation, but not convert the heart back to a normal rhythm. And so typically that's a strategy that uses medications such as beta blockers or calcium channel blockers, and in some cases digoxin to keep the heart from racing and going too fast. And eventually, if those medications are not successful, then it can include putting in a pacemaker and doing ablation of the AV node. And then at that point, the patient's heart is still in atrial fibrillation, but it will not race. So all of those techniques are strategies for what we call rate control. Rhythm control is doing strategies or techniques to actually put the heart back into a normal rhythm and prevent AFib from happening in the first place. So there are a number of reasons that we would consider doing rhythm control. And one of the first ones, and one of the most important ones, is just symptoms, how patients feel. So frequently I will have patients who will come to me in the office and they will be in atrial fibrillation and they'll say, well, I don't know that I'm in AFib. I'm not having symptoms. And last time we talked about the importance as providers of talking to the patient and really probing into their symptoms and how they're feeling and making sure that that really is the case, because often it is not. Oftentimes patients have this impression that the symptoms of AFib are palpitations or heart racing, and that if they don't have palpitations or heart racing, then they really don't have any symptoms from their AFib. And that is not true at all, because the symptoms of AFib can be very extensive. It can include generalized symptoms such as fatigue. It can include shortness of breath, inability to exercise, or decreased ability to do exertion such as going up and down stairs. Some patients can have chest pain or chest tightness if they have AFib and their heart races or goes fast. So there have been many times when a patient has come and seen me And even other providers have felt that the patient was not having symptoms from their AFib because the patient assured them that they were not having symptoms. And the more and more we discussed and talked about how the patient was doing on a day-to-day basis, it sometimes has become apparent that they are actually having symptoms. And I also have found that a family member can be very helpful to this as well, because sometimes a spouse will even notice symptoms that a patient is having when the patient isn't aware of those symptoms. So sometimes a spouse will say, I've just noticed that my husband is just short of breath when we go for walks now. And they weren't short of breath 3 or 4 months ago. This is just a change. Or I noticed that they don't feel like doing the normal exercise or the normal activities that they would be doing. And so when I hear that from a family member, it's very helpful in addressing the AFib. So there's different things that we can do to try to restore normal rhythm. One of the first ones that I'll mention is a procedure called a cardioversion. And a cardioversion is a procedure that is used when a patient is in AFib, and it's for the purpose of restoring normal rhythm.
Well, we're going to talk about that in a little bit, Richard, but before, so it seems like, we want to be in a normal sinus rhythm if a patient has symptoms, and therefore the main reason to get a normal heartbeat is really to improve the quality of life. Is that right?
That's absolutely right.
So I remember years ago, there was this study, the AFFIRM study that was like maybe over 15 years ago. And they compared, patients with, rhythm control versus rate control. They kept people in AFib and just tried to see how they did compared to people where they, did everything possible to bring a normal heartbeat. And it was no change in survival, but patients felt better in the sinus rhythm.
Yeah, that's absolutely correct. So the AFFIRM trial was published about 17 years ago or so. This looked at over 4,000 patients, and it did compare rate control versus rhythm control. And in the end, there really was not any difference in mortality. There was not any difference in stroke or some of those other events. But one of the things that I want to mention is that patients were included if they were greater than 65 years of age, if they had AFib that was likely to be recurrent, some other things of that nature. So while yes, it is true that there was not a difference in mortality that was seen between those groups, it was a slightly older population that was just looked at in that trial. So I think we have to be very, very careful as providers of applying the AFFIRM trial to all patients who have AFib.
That's a very good point. So if you're young and you're working and you're active and you go into these episodes of AFib when the heart goes very fast, you're more likely to be affected by the AFib, and maybe your tendency is more to try to do everything to bring back the normal heartbeat or normal sinus rhythm in the younger patient population, isn't it?
Absolutely. And, I would say that even so in the AFFIRM trial, they included patients who are greater than 65 years old. And my approach is even in patients who are greater than 65 years old, I try to do the same thing. And that is, I find that the vast majority of patients who are in normal rhythm feel better compared to being in AFib. So if we apply the AFFIRM trial, regardless of a patient's age, even if there is no difference in mortality, potentially the quality of life is much poorer. And so I find that most patients, whether or not there is a mortality benefit, they want their quality of life to improve. And if they get back into normal rhythm, and if we keep them in normal rhythm and improve their quality of life, then we're really doing a good service to them.
Right. So before you go into maybe any attempt, to correct and bring back the normal sinus rhythm, is there anything we can do from the point of view of the risk factor modification in some patients? Let's say you see the patient for the first time, they're in AFib, they want to get back in a normal rhythm. You try to kind of work on their risk factors first, or is it just, it's something we should do on all the patients anyway, but does it make a big difference?
Absolutely. And I'm so glad you brought that up. So one of the things that I try to do when a patient comes and sees me for their first visit to talk about AFib and to address what to do is we talk about all the risk factors that are associated with it. And the reason it's so important is that whatever strategy we take, particularly if we're performing rhythmic control of their atrial fibrillation, that treatment strategy is going to be most successful if all of these risk factors are addressed appropriately. And so I talk to patients about there are modifiable risk factors and non-modifiable risk factors. So for example, age is a risk factor for atrial fibrillation, but we can't do anything about age. So it's really not worth talking about very much. And it's a similar thing with genetics. However, there are other things that patients can have a huge impact on, and that includes obesity, hypertension, sleep apnea, and alcohol intake. Now, there are more, but those are the four that I spend the majority of my time focusing on with patients. So research has suggested that a goal body mass index of less than 27 is the best case scenario for patients in regards to their weight. Obesity is a major risk factor for atrial fibrillation, and really getting that BMI down to less than 27 is the best case scenario and really does make a difference in patients. Treatment of sleep apnea. I find that it is amazing the high prevalence of sleep apnea in patients who have atrial fibrillation. And many of them don't realize that they have sleep apnea. So really taking some time to discuss potential sleep apnea symptoms is very important. Alcohol intake is another big risk factor. It has been shown that greater than 2 drinks of alcohol in a day for a man or greater than 1 drink of alcohol in a woman significantly increases risk of atrial fibrillation as well as other cardiovascular problems such as sudden death. So it's important to consider alcohol intake. And then hypertension. The guidelines for blood pressure goals have continued to become lower over the years. And I recommend to all my patients that they have a goal blood pressure of less than 130 over 80.
Tell us a little bit about exercise, because, we always heard about these studies and people doing marathon, as well as in Scandinavia, those athletes, doing this cross-country skiing and skating that would develop AFib. But actually, AFib, exercise is really supposed to be really good and decrease the incidence of AFib. So where do we stand, and why do these high performance athlete, get AFib, but overall exercise is good for you? It's a little bit confusing.
Yes, absolutely. Well, that's a great question. And I'm glad you brought it up, because I enjoy exercise both from a health perspective. I enjoy it on a personal perspective and have done a lot of running in the past myself. So it has a personal implication to me as well. So exercise is one of those things where it appears that there can be what we call a bell-shaped curve, meaning that if someone has too little exercise, we think that that's a risk factor for a lot of health issues. Sedentary lifestyle has been shown to be associated with an increased risk of all sorts of cardiovascular problems, as well as other health issues too. Moderate exercise has been shown to be very, very good from a health perspective. It decreases cardiovascular problems, it decreases diabetes, it decreases blood pressure, and we could go on talking for hours about the benefits of moderate exercise. Excessive exercise can be problematic, or it can be a risk factor for atrial fibrillation. And how much is too much? Well, we don't really know. We see this in endurance athletes. So there are patients who will do endurance athletics such as extensive marathons, where perhaps they run 50 miles a day or 100 miles a day, or Ironman triathlons or things of that nature. And the problem is we don't have a specific rule because we don't really know for patients. So what I do is I talk to patients and say, we know that endurance athletics is associated with a higher risk of atrial fibrillation. At what point does the risk significantly increase? Well, it's just kind of hard to say. And so I think moderation is the key in addressing the endurance athletics. But in a lot of our culture, the bigger challenge is on individuals being sedentary. So I do frequently encourage my patients to be active, get outside, and exercise.
Well, I think it's pretty powerful because, if you can control some of these risk factors, you may not need an ablation at all. You're going to get rid of the AFib. So it can make a big difference. So let's say you're still in AFib and you go through that, you schedule your sleep lab appointment for your patient, and you give all this kind of great kind of coaching, but they're on blood thinners, and you want to start them on medication first, or do you kind of head toward cardioversion and then medication? How do you actually, what's your next step after your risk factor?
Yes, that's a great point. So in our last podcast, we talked a lot about blood thinning medication. So before we do any strategy to get a patient back in normal rhythm, regardless of what their CHADS-VASc risk score, it is important that that person be taking anticoagulation. Even if their CHADS-VASc score is a 0, if we're going to perform a procedure to get the patient back in normal rhythm, they need to be on anticoagulation medication. I find that antiarrhythmic, so let me back up a little bit. We talked about rate control medications such as beta blocker or calcium channel blockers. There's a whole different class of medications called antiarrhythmic medications. And those are medications which are for the purpose of keeping a patient in normal rhythm and trying to prevent atrial fibrillation from happening. So I typically do not use antiarrhythmic medications before performing some of the initial procedures, such as cardioversion, to get a patient back to normal rhythm. It can be done in certain situations. If I expect that it will be difficult for a cardioversion to be performed, then that's a good scenario to use an antiarrhythmic medication. But often I will wait until we actually perform that procedure that I was mentioning, calling cardioversion.
So for a cardioversion, tell us a little bit about this. I mean, a patient is scheduled for a cardioversion. What should they expect? And obviously, they're going to be on blood thinners, and they have to continue that. They go to the hospital, or tell us a little bit about patient experience.
Sure. So cardioversion is just for patients who are in continual atrial fibrillation. So a patient perhaps will come see me. We'll discuss their atrial fibrillation. I will have done an EKG. We'll talk about the fact that the patient is in continual atrial fibrillation. We'll discuss why it could be helpful to get them back into normal rhythm, and then we'll schedule the cardioversion procedure. So it's a procedure that's done at the hospital. The patient comes into the hospital. They will go through registration. They'll change clothes, and the nurses will put an IV in to allow them to receive sedation, which is kind of sleepy medicine. So when we perform the procedure, a nurse will give a medication, which will put them sort of into I call it a happy, don't care sleep state, where they're nice and comfortable and sleepy. Often at that point, we will perform a procedure called a transesophageal echo. And that's where we take a tube that's about as thick as my pointing finger, and that goes down the throat to take pictures of the heart, because the esophagus runs right behind the heart. The main purpose of doing a transesophageal echo is to make sure that there are no clots in the heart. And plus, it allows us to get a better picture of some of the anatomy of the heart. After a patient has had a transesophageal echo and we see that there's no clots or other problems on the inside of the heart, then the cardioversion is performed by a couple of pads that are placed onto the surface of the chest wall. And those pads are attached to a defibrillator, which then can apply a shock to the heart and reset the heart and put the patient back in normal rhythm. And what's important to mention is that sedation is given throughout the procedure. So patients are comfortable, they're asleep, and that allows for the maximal amount of patient comfort in doing the transesophageal echo as well as the cardioversion procedure.
So the patient doesn't feel anything. and you call the power company, you're going to need extra joule delivered to the chest. And basically, it brings the patient back into a normal heart rhythm. You monitor those patients for a few hours afterward, and do they get to go home that same day?
Yeah, typically after waiting about a couple hours or so, then the patient is able to come home or is able to go home. And one thing I want to mention about cardioversion, again, it's only done for a patient who is in continual atrial fibrillation. So if a patient is in normal rhythm, then there's no reason to do the cardioversion because they're in a normal rhythm. There's no need to reset the heart back to a normal rhythm. Or if a patient is flipping in and out of AFib back to normal rhythm, there's not a real reason to do that either because we know the patient's flipping back and forth. So even if the patient comes in AFib and we do a cardioversion, there's a good chance they'll be flipping back and forth from AFib to normal rhythm the following day.
Good. So now the patient's in the normal sinus rhythm. He goes home and comes back to see you in the office. He's back in AFib.
Right.
So obviously he's still on anticoagulation. It looks like he's going to need something else to help prevent that AFib from coming back. What's your next step, Richard?
Yeah, so oftentimes after a cardioversion, it is frequent that I will try to start one of those medications that I was mentioning. We call those antiarrhythmic medications. And antiarrhythmic medications have to be chosen based on a patient's clinical status, and they have to be done with a lot of thought. So there are antiarrhythmic medications that can affect the heart rate, and some of those medications can cause a very small risk of abnormal, even dangerous heart rhythms pending the patient's clinical factors. And so it is important that it be considered whether the patient has left ventricular hypertrophy, thickness to the walls of their heart, whether they've had a previous heart attack or coronary artery disease, what other medications the patient is taking, and so forth and so on. So frequently I will start an antiarrhythmic medication after cardioversion because the cardioversion can reset the heart and put a patient back into normal rhythm, but it doesn't prevent AFib from coming back. And frequently AFib will come back. Now, the advantage of an antiarrhythmic medication is that if it's working and if the patient does not have recurrent atrial fibrillation, then it's great that they can take that medication. But there can also be some real disadvantages too. Sometimes antiarrhythmic medications can have bothersome side effects. Some of them can be expensive, and oftentimes they don't work. The success rate in a lot of trials has suggested that the overall efficacy of antiarrhythmic medications may be in the range of 50% or even lower, and that's not very good. Now, of course, that is dependent on whether a patient is in AFib all the time or whether they're flipping back and forth. So there's a number of things that would affect that success rate. But the bottom line is antiarrhythmic medications frequently do not work. Now, when a patient comes back to the office after a cardioversion, I always try to spend time discussing with the patient their symptoms. So cardioversion gives me an opportunity to discuss with the patient how they're feeling when they were in AFib, which is before the cardioversion, and then how are they feeling when they're back in normal rhythm after the cardioversion. And sometimes the patient knew this ahead of time. Sometimes the patient came in saying, I feel my AFib, I feel poorly, I feel it racing, and now I don't feel that anymore. And so that's simple. But remember the other patient I described who said, no, I don't know I'm in AFib, and I don't think I have any symptoms. It is very frequent that we will do a cardioversion and the patient will come back to the office and will come in saying, boy, I feel so much better. You know, I didn't realize it. I didn't know it, but boy, I was really fatigued and I didn't know it. But, you know, I really was having shortness of breath because, you know, a few days ago, I could just walk a block, and this morning I walked 2 miles. I'm back in normal rhythm. My energy level's better. I'm breathing better. Boy, you know, I really was having a lot of symptoms. I just didn't know it.
They didn't know they felt bad. They thought it was they were getting out of shape or they're just getting older.
That's exactly right. So in the vast majority of cases, even when a patient is just convinced that they're not having symptoms of atrial fibrillation, I'll often recommend to the patient, hey, look, it really can be worth trying to do a cardioversion. And if we do a cardioversion, and if you come back to the office and you really don't feel any differently now that you're back in normal rhythm compared to being in AFib, okay, well, at least we've tried, and now we have more objective data. But those are by far the exception. The vast majority of patients, even when they were just 100% convinced that they were having zero symptoms of their atrial fibrillation, when we do the cardioversion, they will often come back and say they feel much, much better in normal rhythm. And you know, the data is supportive of that too. There have been a number of trials that have looked at patients who were in normal rhythm compared to atrial fibrillation, and the quality of life for the vast majority of patients is better in normal rhythm compared to being in atrial fibrillation.
Well, that's very important. Now, these medications that we want to give to prevent the AFib from coming back, without going too much into detail, can you mention a little bit about some of them and how do you use them? For example, we have the flecainide or erythritol. When do you use that versus sotalol or ticosine, which is a very, very special medication that you have to be certified, to give that drug?
Sure. Sure.
Most of the electrophysiologists, I know
Sure.
as a cardiologist, I don't give that. And then medications that are very kind of popular, but we can see side effects or lack of efficacy when we talk about, Multac versus amiodarone.
Sure.
So just briefly, when do you use those medications?
Sure. Well, just to give a brief summary, there are 6 antiarrhythmic medications. 4 of those can be started on an outpatient basis. 2 of those should be started in the hospital. So to start with, there's flecainide and propafenone, which are very similar to each other. Those are very common medications. They tend to not be very expensive. They're sodium channel blockers. They actually work on the cells in the heart. And we typically will combine them with a beta blocker or a calcium channel blocker. The side effects are relatively minimal in those drugs, but they can't be used in patients who have left ventricular hypertrophy, thickness in the walls of the heart, significant coronary artery disease, a depressed ejection fraction, such as patients who have cardiomyopathy, congestive heart failure, because those medications can increase the risk of dangerous heart rhythms in those patients. And again, the efficacy is decent, but not great. The third medication I'll mention is called Multac or dronedarone. It's a medication which is also taken twice a day. It's a potassium channel blocker. It tends to have a little bit more side effects than flecainide and propafenone do. Some patients can feel a little lethargic or have some GI side effects, and it has to be used with a lot of caution in patients who have congestive heart failure because it can make it worse. It also tends to be an expensive medication, so pharmacy coverage is a big deal for that one. And then the fourth one that can be started on an outpatient basis is a medication called amiodarone. Interestingly enough, it's the most effective medication that we have for atrial fibrillation. But the problem is there is a real risk of pulmonary side effects such as pulmonary fibrosis, thyroid abnormalities, both high or low thyroid abnormalities. And then there's also a risk of liver problems too. The risk of any one of those things happening goes up significantly over time. So the risk of a problem in the span of a few months is relatively low with using amiodarone. But it has to be used with a lot of caution over a period of years. So I typically don't recommend using it in the long run for patients. The other 2 medications are sotalol and difetilide. Difetilide is also called ticosine. Those are both potassium channel blockers, and they can cause an abnormality on the EKG called QT prolongation. Sotalol can decrease the heart rate significantly, so it can only be used in patients who don't have a low heart rate at baseline because it will cause significant slowing in the heart rate. It is not an expensive medication versus Ticasin, also called dofetilide, is a pretty expensive medication, but it does not affect the heart rate in the way that sotalol does. Ticasin is also a really good medication to use in patients who have congestive heart failure. Both of those medications should be started in the hospital. And the reason being is patients can be monitored with continual EKG monitoring, and they can also have EKGs, blood work daily, things of that nature. So it tends to be a somewhat big deal for a patient to come into the hospital for a 72-hour stay to be initiated on those medications.
Well, that's great. So we're trying to reestablish a normal heart rhythm. And we've talked about the risk factor modification. We've talked about the cardioversion. We've talked about the drugs. Now, what about catheter ablation, which is really the cherry on the cake? This is what has changed the field completely over the last several years and has really come a long way. So do you want to tell us a lot about catheter ablation? First of all, who is a candidate for this? And, tell us a little bit about some of the technology. What kind of catheter ablation are we talking about? What does it mean really for the patient?
Absolutely. So I spend a lot of time performing ablation procedures for patients who have atrial fibrillation. It's something I'm very, very passionate about because we've had success performing ablation procedures in patients who have not had success with any other treatment strategy for their atrial fibrillation. And control of atrial fibrillation can have a profound impact, as we were discussing, on patients' quality of lives and just every other aspect of their health. So it's something I'm very passionate about as a result of that. So the procedure sort of got its start back in 1997, 1998 in Bordeaux, France. So there's a really fantastic physician and scientist by the name of Michel Hosseguera. And he was doing studies and he was trying to figure out where was the origin of atrial fibrillation in patients. In other words, where was it starting on the inside of the heart? And so he did a study that was published in the New England Journal of Medicine. And what they did is they put catheters up into the heart and they put them specifically into the pulmonary veins. Now, the pulmonary veins are pipe-like structures that drain blood from the lungs into the left atrium. Of course, the left atrium being the upper left-hand chamber of the heart. And their job is to drain blood from the lungs into the left atrium. But what he found is that there were bits of muscle, pieces of muscle that extended from the left atrium up into the pulmonary veins. And he found that in a high percentage of patients who had atrial fibrillation, there was electrical firing from these muscle sleeves up in the pulmonary veins into the left atrium, and that would initiate atrial fibrillation. And that was a revolutionary finding because before that, the medical community just didn't quite understand where atrial fibrillation was originating from in the majority of these patients. So basically that led to the development of an atrial fibrillation ablation. And the foundation of an atrial fibrillation ablation is doing ablation around the openings of those four pulmonary veins. There's a couple of different ways to do ablation, but the bottom line is the outcome is that there's a goal of a formation of a small amount of scar tissue just outside the openings of those veins. And those ablation lines, as we call them, are a little bit like an electrical firewall, meaning if there is electrical firing on the inside of those pulmonary veins, then it cannot get into the left atrium and it cannot initiate atrial fibrillation. So as you can imagine, the procedure now, 22, 23 years after the publication of that landmark paper, has evolved tremendously. And we've learned an amazing amount about how to do it safely, how to increase the efficacy, and decrease the time required to do the procedure. But that's sort of the foundation of atrial fibrillation, and that's the goal of how we do the procedure and how it produces the desired outcome.
Well, that's pretty good. I mean, I know when I train, if you were an AFib, well, that's it. That's all we can do. We can maybe shock you out of it, maybe give you some medication, but it was very frustrating. It was very difficult, to get a patient back in rhythm and keeping them in rhythm. So the catheter ablation has really kind of changed this field of atrial fibrillation, and is really, despite the fact that it's not a cure, it's certainly a big treatment contribution to improving patients' quality of life. Now, you have these special catheters. Can you explain to us a little bit how an ablation is done? You have this special catheter that really maps the left atrium on this computer, and then you have another special catheter where actually that performs the ablation. I mean, this is really high tech what's going on here in the AP lab, isn't it? I mean, it's like Star Wars.
Yeah, absolutely. So the technology is just absolutely fascinating for the procedures that we're able to perform. And so for a patient who's having an atrial fibrillation ablation, they'll come into the hospital and have the preparation that I was describing before. They'll come to the electrophysiology laboratory, which looks like in the operating room. We use the similar sterile technique as any surgical operating room, but we have an extensive amount of equipment. And there's several tools that we use during the procedure. We use something called fluoroscopy, which is real-time X-ray. We're able to see the movement of wires and catheters in the heart. We try to minimize use of that as much as possible. And then we also have something called three-dimensional mapping. So when we start the procedure, we will place little wires and catheters into the big veins of patients at the femoral sites, which is the groin sites, and sometimes we'll use a vein that goes through the neck. And all those veins are like pipes that drain into the heart. They come into the right atrium, and we put all our wires in the appropriate position. To do the majority of the ablation work, we will put those wires and catheters from the right atrium into the left atrium. And then we actually do the ablation. So there are wires that are positioned in multiple areas of the heart, and those wires can do two things. They can sense the electrical impulses, and then they can pace the heart. And pacing the heart just means stimulating one particular chamber of the heart to beat. All of these electrical impulses are displayed on multiple computer screens that are hanging from the ceiling. And so those refresh in real time. So if someone were to look at the computer screen, they would see multiple lines with multiple spikes, and those computer screens are just continually refreshing based on a patient's heart rhythm and how fast the heartbeat is going and so forth. So that's the purpose of all the wires, is sensing multiple electrical impulses and pacing the heart when appropriate. But then we have one particular catheter that will actually do the ablation itself. And there's two ways to do ablation. There's radiofrequency ablation, which is heating up the tissue or cauterizing the tissue. And then there's another technique called cryoablation, which is freezing the tissue. And there's reasons to use one technique versus the other, but the bottom line is the goal is to perform appropriate ablation at the opening of the pulmonary veins to create that electrical firewall, so no electrical impulses can get in or out of the pulmonary veins.
So I guess even before the procedure, of course, you did your TE again to identify the structure of the left atrium and those pulmonary veins, again, making sure there's no clot. But also a lot of times I think you do CT, or cardiac CT, don't you, to try to identify where the pulmonary veins are, so you have a bit of an idea before starting your procedure.
I do, and that is an approach that is a little variable depending on the center. I request that the majority of my patients who undergo an AFib ablation have a cardiac CT in advance. And the reason being is before we start the procedure, we can perform a three-dimensional reconstruction of the left atrium. We can see the exact anatomy of the left atrium, including the anatomy of the pulmonary veins. Then when we put all our wires and catheters inside of a patient's heart, we create a virtual reconstruction of the left atrium on several computer screens. And this is the other way, this is the primary way that we actually perform ablation. So on our computer screens, we will have a three-dimensional reconstruction of the left atrium that's performed by moving our catheters around the inside of the heart. Of course, the patient's under general anesthesia, so they're totally asleep, just as though they were having a surgery. And on the patient's chest is multiple stickers and adhesive pads that creates electromagnetic field around the heart. And so when we're moving the catheters around, then the software package on the mapping system then creates the three-dimensional reconstruction. But when we're moving the ablation catheter around, we can see it in real time on the computer screens based on the map. And that's the primary way that we know that we're in the right spot. And we can do it with a tremendous amount of precision, down to 1 millimeter. And that's very, very helpful because the exact area of ablation is important on the inside of the heart. And there are structures that need to receive adequate ablation to have an effective procedure. But the flip side of it is there are certain places where ablation has to be avoided, or ablation could cause a complication. And so there's a great deal of precision that's used in performing the procedure.
Now, I know there's going to be some proponent for radio frequency ablation versus cryo, which is mounted on this balloon that you just stick in the pulmonary vein and freezes everything around it. It seems like it would be so much quicker to perform an ablation that way, or is it?
Sure. So cryoablation, as I was saying, refers to freezing the tissue, and it is done with a balloon strategy. So a form of a balloon is placed into the opening of the pulmonary veins, and the tissue is frozen. In some situations, cryoablation can be a little bit faster, but it does have some disadvantages. And specifically, it is difficult to perform cryoablation in any other areas of the heart other than the pulmonary veins. So there are a significant percentage of patients who will need ablation performed in the right atrium for a heart rhythm called atrial flutter. And so if a patient is undergoing cryoablation, then we don't have a catheter to perform the atrial flutter ablation, or then we have to convert the procedure over to using radiofrequency. So I don't use cryoablation, and it's a very specific decision based on just kind of my philosophy for performing ablation procedures. I find that it is very, very common for me to need to perform ablation in areas of the heart in addition to the pulmonary veins. So I feel like the procedure goes smoother by having the ability to do radiofrequency. And again, radiofrequency just means cauterizing the tissue. It's actually heating up the tissue. It's the opposite of the cryoablation strategy. So again, at professional meetings, there'll be just debates and discussions about cryoablation versus radiofrequency ablation, but my approach is to perform radiofrequency on all of my patients.
So basically, you're creating a scar all around the four pulmonary veins and disconnect the tissue near or inside the pulmonary veins with the rest of the atrium, and in that way, bring back the normal sinus rhythm. So that works pretty good in patients that have paroxysmal AFib. That means that AFib keeps coming back and forth. But what about those patients with persistent AFib, where the atrial tissue is not really normal around or even between the pulmonary veins? Can you still do an ablation in those patients?
That's a really great question. So as you were just mentioning, it is important that we address what type of atrial fibrillation a patient has. And it's basically like staging atrial fibrillation. If a patient flips back and forth between AFib to normal rhythm, just as you were mentioning, we call that paroxysmal atrial fibrillation. If a patient has been in atrial fibrillation for greater than 7 days, or if they've had to have a previous cardioversion, we consider that to be persistent AFib. And then if a patient has been in continual atrial fibrillation for greater than 1 year, we consider that long-standing persistent atrial fibrillation. And really what you notice between those three different types, it's not that the AFib itself is different, it's really more the duration of the atrial fibrillation. Because AFib is a yes or no thing. A patient is either in AFib or they're in normal rhythm. And so those three descriptions really describe how long has the patient been in AFib. The reason that that's important is that the longer the patient has been in AFib, the tougher it is to get the patient back to a normal rhythm. And being in atrial fibrillation on a level of the left atrium in terms of how big the left atrium is, and also on a cellular level, it is damaging to the tissue. So if a patient has an episode of AFib for an hour or 2 hours and flips back to a normal rhythm, that's far different than a patient who has been in atrial fibrillation continually for 6 months, because there's a much greater likelihood that there will be significant dilation of the left atrium, and there's a much greater likelihood that there will be extensive formation of scar tissue on the inside of the left atrium for that patient who has persistent AFib. So one of the things that is very important to me is I really believe that early interventions for atrial fibrillation are important. In other words, if a patient is in AFib, try to get the patient back to sinus rhythm as soon as possible. Waiting and then performing a cardioversion or an ablation on down the road is most likely to make things much more difficult in the long run. But having said that, it is still frequently appropriate and frequently very worthwhile to perform an ablation procedure in a patient who has persistent AFib, but it is very different. So we talked about how the pulmonary veins are the main triggers for AFib. It's electrical firing from the pulmonary veins that will initiate an AFib in the majority of patients who have paroxysmal atrial fibrillation. Doing electrical isolation of the pulmonary veins is still the foundation of all ablation procedures, both paroxysmal atrial fibrillation and persistent atrial fibrillation. But I'm a big believer in performing more extensive ablation besides just the pulmonary veins in patients who have persistent atrial fibrillation. It becomes much more complicated because we see things that we refer to as electrical rotors, which are very microscopic rotations of electrical current in the left atrium. Or sometimes we'll see something called reentry, where electrical impulses can go around in a larger pattern. So you can almost imagine in the left atrium electrical tornadoes or electrical hurricanes or electrical sandstorms or whatever other weather analogy you may want to use on a small level.
That's very much
the
season this year.
Yes, exactly. That's right. So this is a little bit of a controversial topic, and different electrophysiologists have different approaches to how they perform ablation of atrial fibrillation in patients who have persistent atrial fibrillation. But I believe that patients do much better with additional ablation besides just pulmonary vein isolation. Sometimes linear ablation is performed where an ablation line will be performed across the roof of the left atrium or across the mitral valve. That's one approach. Rotor mapping and complex electrogram mapping is another approach. And again, those are getting into some very technical and highly specific approaches to doing the actual procedure. But the bottom line is that I do think additional ablation besides just the pulmonary veins ends up increasing success rates for those patients significantly. I do think it's important that a patient understand, especially someone who has persistent atrial fibrillation, that there's a real risk of needing a second procedure. And it's okay for a patient to end up having a second ablation procedure if the first one doesn't work.
So let's talk about these results. If you have someone that goes in and out of AFib and paroxysmal AFib, you go through an ablation. What kind of results are we expecting? Is it 70%, results where the AFib doesn't come back, or 80%? And obviously, you can do a second one and increase your rate of success. How does it actually work?
Absolutely. So when I talk to a patient before undergoing a procedure, I explain that in general, the overall 2-year success rate for a first-time AFib ablation procedure should be in the range of 60 to 85%. Now, that's a little bit of a big range. I'll accept that. But that range very much depends on whether a patient is in persistent atrial fibrillation or paroxysmal atrial fibrillation. I really think that someone who has paroxysmal atrial fibrillation should be on the upper end of that success rate versus someone who's in persistent atrial fibrillation should be on the lower end of that success rate. And longstanding persistent atrial fibrillation can certainly be considered in regards to an ablation procedure, but success rates can be challenging in that patient population. But I will mention this: the risk factors that we discussed before, obesity, sleep apnea, hypertension, and alcohol use. Treatment of all 4 of those things is really, really important. And it's actually been shown in trials before that patients who have optimal control over all 4 of those risk factors can end up having the best outcomes with treatment of their atrial fibrillation, and specifically with an AFib ablation. So when I'm talking to patients in advance about the procedure, one of the things that I like to discuss is, hey, I need your help. This is a partnership. I will do everything I possibly can to give you the world's best ablation procedure. But I need your help in working on all of these risk factors so that we can have the absolute best outcome that's possible.
Well, I think you're right. I mean, several studies that have demonstrated that if you do the risk factor modification, you do improve your results of your AFib ablation. What are the risks of a catheter ablation, Richard? I mean, I know you have these special catheters that are able to kind of detect the force that you apply to the wall of the left atrium, which is very, very thin, by the way. So the risk of perforating, it must be very, very low. But what are other risks that we can see sometimes?
So I talk to patients about the risk of minor complications versus major complications. And in general, what patients really care about, what really has an impact on them, is the risk of major complications. Minor complications could include things like some bleeding from one of the catheter sites in the groin or the neck, or things of that nature. But those are things that tend to be a little bit easier to treat and have less impact on patients. But the risk of a major complication, such as involving the heart, is reported at somewhere in the range of about 2% or so. That can include perforation of the left atrium, which can cause bleeding around the heart. That's something that almost always happens at the time of the procedure. But if it does happen, it means that the procedure has to be stopped and that complication has to be dealt with at that time. Other things can include a risk of clot formation in the heart that could lead to stroke or heart attack, damage to one of the heart structures, such as the pulmonary vein, the mitral valve, the esophagus, which runs right behind the left atrium, or other heart structures. And the vast majority of the patients who end up in that 2% category are able to have treatment for the complication and are able to make an appropriate recovery. But there is risk that any one of those complications can result in a patient needing cardiac surgery or could even be fatal. And so the mortality rate of the procedure is reported at 30 days at 1 in 1,000 patients. So overall, compared to a lot of cardiac surgeries and other things of that nature, it's a very low mortality rate. And compared to other surgeries, it's a relatively low complication rate as well.
So the patient goes home after his procedure, goes home usually the next day. He's in sinus rhythm. Sometimes you've had to do some cardioversion associated with it, particularly, I guess, if you had persistent AFib or long-standing, or sometimes the AFib, you're able to ablate it and it disappears completely. Now, how long after, I mean, obviously you have a lot of swelling. You've been going around with catheters, creating scars. It takes a while to heal. And I guess you're expected to go in and out of AFib sometimes after the procedure, don't you? And that's why you have to keep the blood thinners, throughout, not only throughout the procedure, but even at least several months afterward.
Right. So the approach to using blood thinning medications is that all patients who have an ablation procedure need to be on an anticoagulant for several weeks before the procedure and for at least 2 to 3 months after the procedure. And that's regardless of the CHADS-VASc risk score. So, we talked last time about the CHADS-VASc risk score determines whether a patient needs anticoagulation in the long run, but all patients who undergo ablation have to take it during this time. And that's because there's inflammation on the inside of the heart. And that inflammation can be a nidus for clot formation that can lead to stroke. Now, the risk of that happening is very, very low if a patient is taking anticoagulation. But regardless, the patient has to stay on it for 2 to 3 months after the procedure. At that point, 2 to 3 months later, then I make a recommendation on anticoagulation based on the CHADS-VASc risk score. And that's regardless of whether an ablation procedure was successful or not. So the challenge with AFib ablation is, as we just discussed, that the success rate can be variable. And so there's a significant percentage of patients who can end up coming back with atrial fibrillation. And the further that time gets on, the risk of more AFib continues to go up. So if a patient who has an elevated CHADS-VASc risk score is not taking anticoagulation, then that's a patient who has a high risk for stroke. And if they're not taking anticoagulation, then their AFib can come back and they can end up having a stroke. So I tend to be very cautious with stopping it. In terms of having episodes of atrial fibrillation after the procedure, it really is variable, and it just ends up depending on the patient. There are some patients who have a certain level of inflammation in their hearts from the ablation procedure, and that inflammation can actually trigger episodes of AFib to happen. And so until that inflammation from the ablation procedure decreases, there can be some episodes of atrial fibrillation. So we don't consider the procedure to be a failure if someone has an episode of AFib in the first 2 months. But after 2 months, the inflammation should be gone and the patient should not be having episodes of AFib at that point.
And that means that a lot of times the patient can come off their antiarrhythmic medication.
That's exactly right. So I will frequently use an antiarrhythmic medication for the first 2 to 3 months after an ablation procedure, just to try to avoid those episodes of a patient going back into AFib. But then at the 2 to 3 month mark, assuming the patient's doing well and not having problems, then it is frequently that I will stop the medication and hope that the patient continues to do well and doesn't have episodes of AFib.
Sounds great. Well, listen, Richard, I mean, there's a lot of clinical research going on right now with catheter ablation, and particularly within the last year or so, we've had all kinds of trials, going on, trying to see, I mean, are there benefits to the AFib ablation that is beyond just quality of life? We've had the Cabana trial, that was reported last year. This year, there's another trial that came on, is East AFib in Germany. Can you tell us a little bit more about some of these clinical trials?
Absolutely. So Cabana was a trial of over 2,000 patients who had atrial fibrillation, and this was done in 10 different countries and a total of 126 different medical centers around the world. And basically, the endpoint for Cabana was primarily looking at mortality and cardiovascular events that included stroke, bleeding, cardiac arrest, things of that nature. And the goal of this trial was to randomize patients to medical therapy versus an atrial fibrillation ablation and see if there was a benefit to one strategy versus the other. And the end result of this study is that the investigators felt that there really was not a difference in that primary outcome of mortality, stroke, and some of the other cardiovascular events that I mentioned. But it gets a little bit more complicated than that, because there's been a lot of questions about whether the trial was adequately powered enough. Meaning, were there enough patients included to really determine whether there was a difference between the two groups? Because if you looked at the numbers, in the patients who had an ablation procedure, the numbers of their events were lower. It just was not statistically significant in the trial. And then the other thing that's a little bit controversial is that in the patients who were assigned to medical therapy, 26% of those patients ended up getting an ablation procedure, but they were still included in the medical therapy group. We call that intention to treat analysis, which is an appropriate statistical method, but it definitely causes one to question the outcomes, because 26% of the medical therapy patients ended up having an ablation procedure. There was a sub investigation or sub study that was performed, another analysis. And one thing that they did say, and they did conclude, is that the patients who had an AFib ablation had a significant improvement in their quality of life. So we had been talking about this earlier in the podcast, the whole quality of life issue, and that was certainly demonstrated in Cabana. The other study that you were just referring to a minute ago was the EAST-AF-NET trial, and that was presented just in August of this year at the European Society of Cardiology. Basically, this was a trial of almost 2,800 patients who were in their first year of AFib diagnosis. And they had to have at least 2 cardiovascular conditions. This was a study that was done from 11 countries around the world. And basically, patients were randomized either to an early rhythm control or standard medical therapy. And the rhythm control could include antiarrhythmic medications or an AFib ablations, versus the medical therapy was typically rate control. And so what they were looking at was a combination of cardiovascular death, stroke, worsening heart failure, or acute coronary syndrome. And so in looking at the combination of all these outcomes, what they ended up finding is that it appeared that there was a significant benefit in the patients who had the rhythm control strategy compared to those who had the rate control strategy. And there's some also controversial aspects to this trial, but the bottom line is it just kind of makes one go back to that initial trial that we've been talking about, the AFFIRM trial. And it just leads to a whole discussion about rate versus rhythm control. And it just makes us question that perhaps rhythm control could be associated with some significant benefits that perhaps we haven't acknowledged in the past 15 to 20 years. So these are some really thought-provoking questions that have been raised just in the past few years.
Where is the research going? What's the future for AFib? What's in the cards?
Well, I think, when I think that you look at some of these studies, one of the first things that I would say is that early intervention is really important. Early intervention means we have an opportunity of stopping a patient's atrial fibrillation while it is paroxysmal, before we let it progress to the point that it's persistent atrial fibrillation, and certainly before it's to the point of being long-standing persistent atrial fibrillation. So I think we're already starting to see some impressions based on EAST-AF-NET trial. From a technical perspective, I think that hopefully in the next few years, we're going to see some further answers about how to be more specific in our ablation approach towards patients who have persistent atrial fibrillation. We already see a lot of work being done on rotors, complex atrial electrograms, and other things of that nature. but we don't have really any consensus on what's the best way to approach these things. So hopefully in the not too far away future, we'll have better agreement on how to approach these patients in terms of their ablation procedures. And then, of course, there's the additional topic, and that is of anticoagulation and using anticoagulation versus an interventional approach to help patients get off of anticoagulation. And of course, that's a whole nother topic in and of itself.
In another podcast. I know that if
That's
I get AFib, Richard, I want an ablation. Well, listen, I want to thank you very much. I mean, that was really kind of a great review and overview of AFib, the consequences of AFib, our approach to treatment of AFib, and it looks like the future is bright. Not only because we have a lot more patients with AFib, but there's something now that can be done, and really, without being a cure, certainly it can improve on, maybe prognosis, and certainly the quality of life is really a big factor in these patients, particularly with the ablation. Richard Vess, thank you very much. I appreciate it. And we hope to talk to you maybe next time for some other type of ablation, maybe about the atrial flutter, or maybe some of these devices, where we don't need anticoagulation anymore.
Hey, it's my pleasure. Thank you so much for having me.
To learn more from our team of cardiologists, please visit us at MyHeart.net. You can also follow us on social media by searching MyHeart.net on Facebook and Twitter. And be sure to subscribe to this podcast so you don't miss our next episode.